Good morning, good afternoon, and good evening to everybody joining us online. My name is Sheila Krishnadath, and together with Prateek Sharma, we are your chairs for today's presentation on multidisciplinary approaches to early Barrett's cancer. Thank you for participating in our third live presentation. As you may know, the International Society of Diseases of the Esophagus mission is to promote the exchange of scientific and medical knowledge of the esophagus among specialists in the field. And we are happy to bring you this virtual presentation and discussion. We would like to have a lively discussion and like to have you interact during the session. So after each presentation, you have the opportunity to send us questions. Please use the question and answer box for that. And stay tuned because we may not be able to answer all these questions within these 3-minute slots. But at the end of the presentations, we have another 15 minutes to talk to you. So we do have a list of outstanding speakers, starting with my co-chair, Prateek Sharma, past president of the ISDEs, who will be talking to us about advanced endoscopic imaging for diagnosis. Prateek, the screen is yours.
On behalf of the ISD, along with Sheila, it's my pleasure to co-chair this webinar on a multidisciplinary approach. And I'll be spending a few minutes talking about, different advances in imaging in patients with Barrett's esophagus and esophageal adenocarcinoma. Now, if you look at innovations in esophageal endoscopy for Barrett's esophagus, you can separate them out into diagnostic and therapeutic innovations. And, the ones that I'll be focusing on would be advanced imaging, and then a few words about artificial intelligence, because that for all of us in the field of medicine has been something that we are looking forward to and will revolutionize how we perform endoscopy in our patients. So let's get started first with what we have currently about advanced imaging. High definition white light endoscopy is something that we practice today. And this is a gradual pullback in a patient who is undergoing surveillance for Barrett's esophagus. There is a C0M4 Barrett's esophagus. And right here at the 11 o'clock, 12 o'clock position with my mouse here, you can already see an early Barrett's adenocarcinoma coming into view. It's a subtle lesion. However, unless you wash the esophagus, you're taking your time in inspecting the esophageal mucosa. This is an early cancer that can easily be missed. And this is the critical step in imaging of our patients with Barrett's esophagus. Here are other subtle early cancers in patients with Barrett's esophagus, which are pointed by the yellow arrow. In the 4 quadrants, you can see them. This is a slightly depressed lesion, and again, representing an early cancer in a patient with Barrett's esophagus. This is a GE junction cancer arising again in a patient with a short Barrett's. You can see that the extent is probably about 1 centimeter. This highlights the importance of a good retroflexed examination. You can see in which the cancer is clearly visible both on the antegrade as well as in the retrograde view. You can spray indigo carmine to try to highlight if there are other subtle lesions within the GE junction area, and that all looks normal in this situation except for that 1S lesion that you can see right at the gastro-esophageal junction. Now, besides spraying dye, you can use virtual chromoendoscopy, in this situation, narrowband imaging. However, you can use BLI or iScan, whatever you have available. This is, again, a subtle cancer at the gastro-esophageal junction in a patient with Barrett's esophagus. This is the lesion which is visible also with white light endoscopy. Of importance, this is flat high-grade dysplasia extending probably from the 11 o'clock position You can see the lesion, but you can see that it's more extensive and covers all the way up to about the 2 o'clock, 3 o'clock position. So both spray endoscopy as well as virtual chromoendoscopy can help us in delineating the lesions as well as in recognizing lesions in the distal segment. This is a patient, again, undergoing surveillance, C0M1 Barrett's esophagus, and after spraying indigo carmine, you start seeing some area of an erosion right at the 2 o'clock position. You get there with narrowband imaging, and then you zoom into it, and you can see again a highly subtle 3 to 4 millimeter area of early cancer within Barrett's esophagus. This is flat mucosa, which has a regular pit pattern, and this is non-dysplastic Barrett's, whereas this is the cancer and this is the flat high-grade dysplasia alongside with it. So I've shown you examples right from 1S lesion, which you can see with high definition white light endoscopy, to spraying of dyes, to actually virtual chromoendoscopy with highly subtle lesions, measuring in millimeters within the Barrett's esophagus, just showing you what it is. Now, these criteria, which I've shown you, are called the Bing criteria, or the Barrett's International NBI group. And when we looked at these criteria, at least in the hands of experts, you could see that a very high negative predictive value for these criteria was recognized, showing you that these can be used, at least in the hands of experts, to do it. Acetic acid chromoendoscopy in Europe is something which is used. It is a simple technique. And this is, again, flat Barrett's mucosa. After spraying acetic acid, you can see the aceto-whitening reaction, and you can see a red area, which is now being highlighted with the circle. And that shows, again, an area of high-grade dysplasia within Barrett's esophagus. Now, what are all these techniques which are available, and which ones can you use in practice? Now, the American Society for Gastrointestinal Endoscopy did lay out certain criteria of what an advanced imaging technique should meet in terms of its performance characteristics. And if these thresholds are achieved, then these techniques could be used by endoscopists practicing, Barrett's diagnosis and treatment. And currently, the imaging techniques which meet these criteria are virtual chromoendoscopy with narrowband imaging, as well as acetic acid chromoendoscopy. Now, something new which is being looked at is the Watts 3D endobrush, and this is something also which the guidelines have given a recommendation for. And this is a widespread area technique in which, for flat Barrett's mucosa, you pull out the brush, you brush it in a 360-degree fashion. It gives you a higher sampling rate, and then these cells by cytology, which are collected, are then sent for a central pathology reading. And it has been shown to increase the yield of high-grade dysplasia in a multi-center trial in the United States. So that's discussing imaging and things that are available right now. And then a few words about artificial intelligence, because this is something I'm sure all of you are hearing about. And this is what will change our practice of endoscopy, not just for Barrett's endoscopy, but luminal endoscopy in general. And the field of AI, which is machine learning, is the one which is being applied to the field of gastroenterology and specifically endoscopy. Computer vision, in which the computers learn to perform tasks which the human mind is able to do. They're able to analyze data and then generate decision-making algorithms. And by deep learning, you use multi-layer neural networks, and these have been applied now to the field of gastrointestinal endoscopy. So what are some of the potential applications in Barrett's endoscopy? Lesion recognition, lesion characterization, showing you where the abnormal areas are within the Barrett segment, and also for folks like Ken and Senchuti doing ISDE and EMR, telling you what the extent of the lesion is, which needs to be resected. For example, a photograph here of a cardia lesion. This is a cardiac cancer. And this is with the help of a machine showing you what the extent of that lesion is, which will help with resection of this lesion. Several proof of principle studies have now been published looking at this, and this is from a group at UC Irvine, looking at a patient undergoing endoscopy with narrowband imaging, and the bounding box appears automatically, which starts highlighting the area of abnormality. Now, not does it only do that, but if you look at the dysplasia prediction, it will tell you what is the likelihood that this area is neoplastic. And you can see that in this area, it's varying from about 85 to 95% of prediction that this may be an area of abnormality within the Barrett segment, which is being seen. This is the German experience using this, which was published in Gut a couple of months ago, in which they also have the preview screen, which is on the left of the monitor. And then it gives you this heat map, so as to say, which tells you the extent of abnormality within the area picked up by the machine. Here's one example of looking at a patient with a flat area right here. Off the bat, you can see that the area is flat and appears non-dysplastic, and this is exactly what the machine is telling you, the probability that there is no cancer within that area. On the other hand, here is a visible lesion that you can all appreciate even on white light endoscopy. And when you bring it closer to it and apply machine learning to it, it tells you that there is a 99% probability that there is cancer within that area that you're looking at. And it also tells you the extent of cancer within that area with it. So these are several studies which are coming out telling us how AI can help us looking at it. This is a meta-analysis or a pooled analysis from 6 studies published in gastrointestinal endoscopy. You can see that it's only from about 560 images, telling us that these data are still in their infancy. And then they looked at the AUCs and they did perform extremely well. But part of the reason is, again, that these are initial concept studies and do show that either CNN versus non-CNN based algorithms perform equally well in looking at detection of neoplasia within Barrett's esophagus. So to conclude, for diagnosis and imaging, what I've shown you is that neoplasia and Barrett's may present as very subtle lesions. And so you have to be extremely careful while performing your endoscopy in this patient population. Advanced endoscopic imaging may help the detection of these early lesions. And AI is evolving and is the wave of the future and will change how we practice endoscopy in patients with Barrett's esophagus. So thank you all for joining us this morning, afternoon, and evening for this ISDE webinar. And Sheila, over back to you.
Thank you very much, Prateek, for this wonderful overview. We have nice minutes for questions. So I'm looking at the question and answer box. So I would like to ask everybody who has questions to include their questions in the question box. I don't see anything appearing yet. I don't know if the hosts have something. So Prateek, about the artificial intelligence that you just showed us some nice, and I really believe this is the future. So how far are we with this development? So how easy is it to implement this in an endoscopy suite?
So yes, that's a good point, Sheila. I mean, currently there are no commercially available systems for artificial intelligence for upper endoscopy at this point. Right now, what we have available are primarily, plug and play devices and algorithms which are available for colonoscopy, for polyp detection, for polyp characterization. That's what's available. The studies that I showed you are the studies which are being conducted, have been published, and studies for approval of these devices are just starting right now. So I'd guesstimate that these will be available sometime in 2021, that these devices will be available in the market. I hate to say it, but I think they'll be available first in Europe and then, in the US. So Sheila, one of those rare opportunities in which Europe is ahead of the Americas. So.
Oh, okay. Well, thank you, Prateek. That is interesting, and we are going to wait for that. I have a question here that I would like to ask you, and this is a question by Edward Chong. What technique do you use regularly for your regular Barrett surveillance in your hospital today? Do you see that question, Prateek?
Yes, I do. Thank
Okay.
you. So yeah, that's so. Currently, what we perform is high definition white light endoscopy, followed by narrowband imaging. That is our standard for all patients who come for endoscopy or for surveillance in that order. What we do is, and this is something that one of our former fellows, Neil Gupta, who's the editor, as you know, for the ISDE journal, Diseases of the Esophagus, he published a very nice observation in patients with Barrett's undergoing surveillance that the number of lesions diagnosed was directly proportional to the amount of time being spent in the esophagus, so very similar to the colonoscopy withdrawal time. And this has now been shown from Korea and from Japan for gastric lesions as well. So take your time. We roughly estimate that you need anywhere between 40 to 60 seconds per length of Barrett's esophagus segment. So wash it carefully, get rid of all the bubbles, get rid of the bile, which we typically see in these patients, do a gradual pullback, and then we will then go to an overview mode with narrowband imaging, and then a near focus, with that, and before we take our biopsy. So actually examining is much more important than taking the random biopsies.
Yes, exactly, because this is the next question that I see on screen. Is the Seattle era then behind us? This is a question from Simon Law.
First, I just wanted to say hi to Simon, and hope he's enjoying Hong Kong right now. So Simon, welcome. Seattle biopsy protocol. So, our ASGE and AGA both came up with a white paper in which, going back to that PIVI statement that I had shown, is that it went on to say that if endoscopists feel that they have acquired expertise in one of these techniques which meet the PIVI criteria, which is acetic acid chromoendoscopy and virtual chromoendoscopy, if you think that you're good at it, you can do targeted biopsies only and move away from the Seattle biopsy protocol. So we do have guidance statements which tell us that that's something which can be done. Unfortunately, what's happening in practice is that everyone's quite busy and they're sort of in a rush, and they do a quick examination and just take a few handful of biopsies. So that's probably not the right practice. The Seattle protocol has been shown to be better than just doing 1 or 2 biopsies. So what my recommendation is that if you can spend the time, just like what I have described, and as many of the experts like Ken, Sheila, and I'm sure Simon and Lawrence, who by the way are the chairs of our education committee, as to how they practice it. I mean, we can get away from those random Seattle biopsies and do target biopsies. But otherwise, I would still, rather than taking 1 biopsy here and there, doing the Seattle biopsy protocol is much better than just doing 1 or 2 biopsies.
Okay, thank you, Prateek. I see some more interesting questions coming up, and 2 questions of those are addressing the artificial intelligence. So I would like, perhaps you can have a look at the question of Paul Wilkerson. He is asking, will AI algorithms be good enough to replace all the other things that we have been using nowadays? Actually, I think you partly already answered to this question. But
right. So, I mean, so Paul, I mean, again, a very good question. And, you know, the short answer is that time will tell as to how good these algorithms are and how they will assist us. Currently, I would say that these will be techniques which will be, as you are correctly pointing out in your last statement, that they will be additive to your regular endoscopy. So don't expect them, you know, to replace, you know, your good examination. The AI or the machine can only see what you're seeing, and it can point out what's abnormal in there. So a good example is that if you do a fast withdrawal during colonoscopy and a polyp which is behind a fold does not come into view of your screen, the machine's not going to pick it up because it's not seeing it. So I think it will be as good as you are. So it will just help us. It won't replace us. So that's, you know, my thing that will happen with it. There was another question about biopsying the irregular GE junction. And, you know, the short answer is that, you know, if the Z line is just mildly irregular, and the way I define it is that if you try to open your biopsy forceps and you have a hard time trying to fit that irregular Z line in the biopsy forceps, then I don't biopsy it. The guidelines from the US and Europe are now quite clear that if the length of the irregularity is less than 1 centimeter, don't call it Barrett's and don't try to take, you know, biopsies off that. And I see Lawrence there also from Singapore. So hi, Lawrence. And, you know, Lawrence's comment is that the images I showed were quite nice. And Lawrence, obviously, as you can imagine, to make myself look good, I was using only the good images and not the bad ones. So we always show those. You know, and again, Lawrence's comment is that will this replace, you know, our regular endoscopes and stuff? And again, Lawrence, it's the same comment is that they won't, but can we replicate this in daily practice? Again, those will be the effectiveness studies, which will have to come out from community doctors performing this and seeing what their performance is in there. So there's a lot of unknown right now. I think AI is there today, as I would say, where NBI and BLI and iScan were, you know, about 15, 20 years ago when they were just being introduced and nobody knew how to use it. So there will be a learning curve. We will see, you know, what happens, you know, with it. Andre's question is about using a cap. And, you know, that's a very good question. And I use a cap if a patient has been referred to us for evaluation of dysplasia, because the cap really helps you get closer to the mucosa, helps you do a better magnification, keep that focal length right there. So I don't use it routinely for all cases, but I will do it when I'm suspecting dysplasia or somebody is being referred for that, to look at those small lesions. So Andre, you're right about, you know, how to use the cap in that. Wolfgang's question is about recommendations for surveillance, differences between short and long segments. You know, unfortunately, the US guidelines need to be updated. We don't differentiate between short and long segment. I think we should start doing it. And hopefully when Ken Wang writes the next guideline, that hopefully he'll take, you know, Wolfgang, your recommendation into consideration. So I think it definitely needs to be done. The ESGE guidelines recommend that for long Barretts, which is 3 centimeters or greater, it should be about 2 years or 3 years. And for the short Barretts, it should be about 5 years. So I think we need to have differential recommendations. The US guidelines just say in general, it should be, you know, 3 to 5 years.
So right now it's also European.
Yeah, exactly. Sheila, do you agree with that concept about short versus long?
Yeah, I agree with that. The only thing I wonder is, Prateek, you said that you don't biopsy the irregular, so the very, very short. So if you also at first sight, you don't take one time a biopsy, and after that, when it's okay, you send them away. Because I remember having these cases of, you don't even see a Barrett's, and you have on the Z line, you have a cancer. So
yeah, so that's a good question, Sheila. I mean, so yeah, so my answer is with a caveat, and thanks for pointing that out, is the caveat is, of course, if you see something abnormal, right? I mean, if you see something abnormal, irrespective of an irregular Z line or an absolutely normal Z line, you would still resect that lesion or take a biopsy of that. So that's absolutely right. So my response was in a flat area in which there's nothing abnormal. What happens is that I think we overcall Barrett's, and then you have, and Sheila, as you and your group have nicely shown, that it's probably not cost effective in certain situations to survey everyone with Barrett's esophagus. And if we start biopsying these irregular Z lines and cardia-intestinal metaplasia, I think we will just expand this pool of patients who may not have Barrett's esophagus.
No, absolutely.
Sheila, do I still have time? Because
I think we can do
to run late,
and then we will move to the next speaker.
Okay, sure. So the last question from James is, about high-grade dysplasia in patients with esophageal varices, and what's the role of endoscopic therapy? And again, a very important clinical question. What I do is try to treat the varices first, and then the area of high-grade dysplasia. So once you've decompressed the varices, then you can safely do EMR in that situation. Again, Ken and his group has shown that can be done. But also keep in mind that if a patient has large varices and has a MELD score of 30, maybe liver transplantation and his liver disease is more important than that focus of high-grade dysplasia. So keep that in mind when you're dealing with varices and high-grade dysplasia.
I also, in my opinion, I also have few patients that have no dysplasia and they come for surveillance and they have varices. What I normally do is take a brush instead of biopsies. So I don't know if the Watts 3D brush could be used for that, but that also is quite safe to do. I have never had any difficulties doing that.
Good point. So I mean, I don't think it's being tested in that situation, but I think it makes total sense, to do that. And again, your point about the brushing's good. And of course, keeping just the overall patient in mind, because, doing surveillance or resecting a high-grade dysplasia in somebody with advanced liver disease probably is not going to impact their lifespan.
Yeah, that's always true. So, okay, I think we are right on time now. Prateek, thank you very much, and also for taking for this beautiful presentation, taking care of the questions.